Bismillah ar-Rahman ar-Rahim. My dear students, for the course Biopharmaceutics and Pharmacokinetics 2, third year students of Ajman University. Today we will continue part 2 of the clinical applications of pharmacokinetics. Part 2 of clinical applications of pharmacokinetics. Previously, or in part 1, we discussed about what are the different things in children that can influence the pharmacokinetic of the drug. Now, in this part, we will look at how we do the dosing. Yani if you are in a situation where you are asked to recommend a dose for children, how you'll do that. And we will also talk about the geriatric population or the elderly. To start with dosing recommendations. When we talk about the first year of age, then the dosing recommendation should be based on the drug leaflet, or it should be based on certain references such as Lexicon Pediatric, and this is also available online, or a handbook called Neonatal Dosage Handbook. Usually, it's better always to refer to the primary literature, especially when we deal with the very young infants or the neonates. Okay, primary literature means, these books, even Lexicon Pediatric, might be little late, while a new primary literature is there. But you may not find the information of this primary literature for Lexicon or Neonatal Dosage Handbook. So primary literature will be very useful in this regard. Once the child goes above 1 year of age, once the baby or the infant passes the 1 year, usually it will be possible to adjust the dosage or the dose of the drug based on the adult's dose. Yani we base our dose on the adult's dose, taking into account the differences probably in weight, body surface area, or age. One of the equation that we may use to do that اللي هو Clark's rule. Clark's rule. Okay. Clark's rule takes into account the weight. Okay. Then how do you calculate the dose for the child? He asks you to divide the weight of the child in pound, divided by 150, and then multiply that by the adult's dose. It's known that 1 kilogram of weight is equivalent to almost 2.2 pounds in weight. أو 1 pound is equivalent to 453 to 54 gram. 453 to 454 gram. Okay. Anyway, you need to memorize this conversion because it's common. So an equation that is based on weight, اللي هو Clark's rule, وزي ما حكينا, it's the weight of the child divided by 150. طبعا the 150 here represent the ideal weight of an adult, which is equivalent تقريبا to 68 kilograms. Okay. So you look at this ratio and you multiply it by adult's dose. The body surface area have been shown better correlation with the required dose. So you divide the surface area of the child, the body surface area of the child, by the body surface area of an ideal adult, and then you multiply it by adult's dose, and this is how you can calculate the body surface area, although there are different methods to calculate the body surface area. This is one of them. The third approach is to take age, and this is in Young's rule. Young's rule. See, the equation that defines or allows you to calculate the dose is by taking the age of the child, and in this case has to be older than 2, and then divided by the child's age, then add to that 12. Okay, and this you multiply it في adult's dose. So we have different approaches. We may use one of them once the child exceeds the age of 1 or 2 years old. The geriatric consideration, which we will talk about now, is very important, especially that we are seeing increase in the proportion of geriatric population. يعني صار عندنا ايش؟ The age is increasing هلا يعني because of better hospitals, better medicine, better care. We are seeing that the percentage of older people or elderly are getting higher. Now, and you know that most of the drugs are taken by this group, يعني considering that they are not as high as, for example, the adults, we will see that they are taking a significant number of medication. They found that the toxicity from the drug increases 7-fold, يعني 7 مرات, when you increase in age from 20 to 79. يعني as you increase in age, the toxicities from drugs increases. And of course, we expect that this is partly because we are taking multiple medication. Elderly group is considered as a focus group because they are taking many medication. Okay, and toxicity increases in this group because, as you expect, there is drug interactions. But we need also to consider that there is also change in disposition or ADME processes in the elderly, and we need to talk about this. إذن في هناك changes برضه في ADME processes, as we discussed. حتى في البيدياتريك قلنا في هناك changes. Here we also have changes. The table you see here summarizes very well what we want to talk about. For example, في الالدرلي شو بصير في الجاستريك acid secretion؟ زي البيدياتريك, similar to pediatric, it decreases. إذا شو بصير في pH؟ increases. طيب GI blood flow, gastrointestinal blood flow also decreases. Pancreatic trypsin decreases. GI motility decreases. For some drugs, this can alter the absorption. Also, the dissolution of the drug is altered, and probably a delay in absorption can happen. لما نحكي على distribution, we need to talk about body composition والbinding, لأنهم بيأثروا, they affect where the drug gets distributed. Now, regarding the water, the percentage of water in the body, this decreases along with the lean body weight. طبعا lean body weight هو the total body weight minus the body fat. نحكي له lean body weight. The body fat increases, and for female it's usually higher than male. عشان هيك, because body fat increases, بنلاقي إنه lipid soluble drugs volume of distribution increases. بينما الpolar drugs, which depends on the water and on the lean body, بنلاقي صار في هناك usually decrease في distribution. أما for protein binding, they found that for albumin, it may decrease, while for alpha 1 acid glycoprotein which binds to weak basic drugs increases. إذا في عندنا decrease في الألبومين but increase في glycoprotein alpha 1 acid glycoprotein اللي هم هذول الميجر. Now because of that واحنا عارفين انه الالبومين binds to acidic drug بنلاقي انه free fraction of acidic drug increases, بينما for basic drugs either does not change, okay, if the alpha 1 acid glycoprotein does not change, so it will not change, or it will decrease the free fraction if the alpha 1 acid glycoprotein increases. طيب الميتابوليزم بنلاقي انه الانزيم induction what induces enzyme decreases, not as usual. Hepatic blood flow decreases. الهيباتيك ماس اللي هو الماس تاع الليفر decreases. الاسيتايليشن does not change, بينما الجلوكورينيديشن والميكست اوكسيديز function decreases. Okay. طبعا this will cause decrease in metabolism and clearance. عندنا الاكسكريشن الGFR glomerular filtration rate decreases, renal plasma flow decreases, will active secretion also decreases, and the overall there is a decrease in renal clearance. Okay. طيب, this is the summary of everything. Now if we want to talk about this in more details, the absorption, okay, في عنا we said that there is increase in pH because of a chlorohydria or decrease في gastric acid secretion. في عنا reduction في GI motility, and that might cause reduction في absorption for the actively absorbed material or drugs such as galactose, calcium, vitamin B, iron. أما for most drugs that are absorbed passively, and you already learned about active and passive absorption في biopharmaceutics and pharmacokinetics 1. For most of these passive absorbed drugs, they are generally not affected, with certain exception. For example, tolbutamide, which is given for type 2 diabetes, بنلاقي انه هناك there is reduction في التي ماكس، كأنه في هناك absorption faster. Okay. For distribution, the body fat increases from 15 to 30%، بينما بنلاقي انه هناك طبعا the higher the fat بصير the lower is the lean body، لانه اللين body عبارة عن the total body weight ناقص الفات. And because of that بنلاقي انه for drugs that stay in the central compartment بنلاقي انه الapparent volume تاعهم بيكون lower. Okay. بينما for lipid soluble drug بنلاقي الapparent volume بيكون higher. فمثلا for example diazepam and chlorodiazepoxide اللي هم عبارة عن benzodiazepines، بنلاقي because they are lipid soluble بنلاقي their volume is larger. For example compared مع مثلا lorazepam oxazepam بنلاقيهم relatively unchanged. طيب كيف how diazepam and chlorodiazepoxide the apparent volume becomes larger, while for lorazepam and oxazepam they relatively unchanged? This can be explained by the lipid solubility of the first two اللي هم الdiazepam و chlorodiazepoxide بنلاقيهم much higher than the second pair اللي هم lorazepam and oxazepam. عشان هيك بنشوف lorazepam و oxazepam ما تغير, did not change, the volume of distribution did not change. Okay. When we talk about proteins, the total proteins concentration عادة بيكون constant, but بنلاقي انه الالبومين decreases while alpha 1 glycoprotein increases عشان هيك التوتال remains the same. طيب we have to pay attention to phenytoin. phenytoin اللي هو weak acidic binds to albumin. بنلاقي انه الفري دراج تاعه increases with age from 25% to 40%. معناته صار عندي more free drug, and that is because الالبومين concentration decreased. بس I need you to explain this. As earlier described, this would also lead to increased clearance. يعني الفينايتوين okay, we have more free drug, but because there is more free drug حسب ما أخذته بالميتابوليزم, because there is more free drug برضو عندنا في هناك more clearance, فبالتالي it will remain the same. بالنسبة للdiazepam, which is weak basic, opposite, it has been found that the percentage of unbound could be correlated with age for female. إذا بتأثر لكن mainly في الفيميل, not the male. طيب, we have also to pay attention that drug-drug interaction involving protein binding, يعني displacement, can be more pronounced in the elderly. This means that if a drug-drug interaction is there, على البروتين binding بيكون more pronounced, more significant في elderly population. Also, we should consider cardiac output, اللي هو blood flow. وهاي, and this انتبهوا عليه when I talked about congestive heart failure before. طبعا cardiac output will reduce في elderly, and this may be also associated with heart failure. بنلاقي عندهم cardiac output is less. فبنلاقي انه الفلو ليميتد drugs, هنا بدكم ترجعوا للميتابوليزم, بيتأثروا because they are related to blood flow. So for high extraction drugs اللي هم classified as flow limited, بنلاقي انه they will have an altered overall elimination. Okay, go back to the metabolism to find out examples of such drugs. راح تشوفوا propranolol ومورفين etc. طيب, metabolism, we already said that the blood flow and the liver mass will decrease في elderly. الالبومين, we already said that it decreases. أما بالنسبة للintrinsic clearance, يعني how much enzymes are there are capable of functioning, is quite variable. ما في عنا again general rule. But what we can say is that for drugs that undergo phase 1 metabolism, بنلاقي إنه الميتابوليزم reduces with age. Okay. أما for drugs that undergo phase 2 metabolism, بنلاقي إنه generally there is no change في الميتابوليزم such as acetylation and glucuronidation. Okay. طيب, elimination, الكدني is very well affected with age. For example, بنلاقي إنه with age the kidney or the glomerular filtration decreases by 20%, number of nephrons decreases by 35%, number of functioning glomeruli decreases by 30%, renal blood flow decreases by 40 to 50%, and this will cause an overall reduction في renal clearance. طبعا what do you expect? إنه بما إنه renal clearance is reduced, what you expect إنه الكرياتينين, serum creatinine will increase, لأنه now the creatinine is not getting out easily. But you may be surprised that the creatinine concentration decreases But this is explained that it is because of reduced mass muscle. We said about this, or we talked about this, that the less muscle, the less creatinine is produced, وبالتالي the less the concentration. Okay? When we see a low concentration of creatinine in the serum, that does not mean, there is something strange with the elderly. We may expect that, and we may expect also high creatinine when the kidney is really functioning bad. Okay. Now, one of the most used equation for adults aging 18 or above اللي هو Cockcroft and Gault equation, which allows you to calculate creatinine clearance. ونتذكر why we need to know creatinine clearance. طبعا because we can link that to the clearance of the drug. If the creatinine clearance is low, most probably the drug clearance will be low. Okay? فإذا one of the most commonly used equation to بدناش نحكي calculate, نحكي estimate. This is the right term. To estimate creatinine clearance for us, or in order to assess the kidney function, اللي هو Cockcroft and Gault equation. What does it say? It says the creatinine clearance in ml per minute is equal to 140 minus age in year multiplied في البادي weight بالكيلوغرام divided by 72 multiplied بالserum concentration of creatinine expressed as milligram per deciliter or milligram percent. Okay? Now this equation is for the calculation of creatinine clearance for male. For female, you use this equation and then you multiply it by 85%. The question is, why do we need to multiply it by 85%? Does that mean in all female patients or female individuals, do they have less clearance than the male individuals? La, it's not this. The reason is the serum concentration of creatinine في الفيميل is less. هذا الدينومينيتر هون is less في الفيميل. فمعناته if I keep it the same as the male, their creatinine clearance will be more than the male. In order to have the similar creatinine clearance, whether male or female, I have to multiply it by 85%. This equation again applies for adult population. Number 2, which is very important, when kidney function is stable, يعني it's not changing with time, because we have situations where kidney function changes with time. You cannot use this equation. There is another one. Okay? This is the equation you will use to calculate creatinine clearance. And you will see here how digoxin clearance, طلع digoxin clearance, is linked to creatinine clearance. وبنعرف, we know very well that the clearance of the drug is linked to the concentration of the drug and to the dosage regimen. The clearance of digoxin is equal to A طبعا will be 0.88 for a patient with acute heart failure. Otherwise it will be 1 if it doesn't have, or congestive heart failure. أما B will be 23 for patient with acute congestive heart failure. Otherwise I will use 40. C is a correction factor for any interacting drugs. Anyway, what I mean to say here is we can calculate the digoxin clearance based on creatinine clearance. And that's the importance of Cockcroft and Gault and the clearance of the drugs that are mainly removed from or by kidneys. Okay. طيب في عنا some drugs which include زي الامينوجلايكوسايدز. اوكي. والديجوكسين والليثيوم والميثوتروكسيت والكوينيدين و a lot of tetracyclines بنلاقي انه their clearance is linked or is related to creatinine clearance. It's not the same, but it's related to that. And I gave you an example اللي هو digoxin. طيب, what you see here is what you expect normally for adult male. انه الكرياتينين concentration is between 0.8 ل 1.4 ملغرام per deciliter. deciliter يعني 10 لتر، يعني 100 ml. Or sometimes I just say milligram percent. أما for adult female it's from 0.6 to 1.1 milligram per deciliter. For children, but again I do not use this في الكوكروفت and Gault equation, we expect to have between 0.2 to 1 milligram per deciliter. The creatinine clearance for children they use another equation, not Cockcroft and Gault. Okay. طبعا in this table they summarize many of the things we talked about. What happens to the apparent volume distribution. طبعا لما نحكي apparent volume distribution we have to consider the proportion of fat and the proportion of water. We have to consider the binding and the clearance. For the clearance we need to consider metabolism and renal clearance. Okay, and look at the difference between the two, adult and elderly. When we make those recommendations for elderly, we have to differentiate between two groups of patients. Long-term care patients that are immobilized and they do not move and they have diseases, and those who are healthy and active and living in the community. I cannot say that someone who's very healthy, keeps moving, doing sports, I cannot say that one is similar to the one in the hospital who's having diseases, cannot move. I cannot treat them as having the same pharmacokinetic parameters. Isn't I have to consider the elderly and see other situation that might change my plan in case of dosage regimen. Also, I have to consider that for some drugs, زي الامينوغلايكوسايدز. Okay, aminoglycosides هذا antibiotic. إنه الدوزج فيه adjustment of the dose is progressive. I keep changing the dose, and the reason of that is that aminoglycoside is toxic to the kidneys. But sometimes I need to use aminoglycosides in certain infections. It's cytotoxic to the kidneys, so the kidney will start to have reduction in its function with time. I cannot keep the aminoglycoside antibiotic dosing the same. I have to reduce it with time, okay? As the creatinine clearance also changes, so I have also to change the dose of the aminoglycosides. So in those recommendations, I have to consider the parameters for the elderly. In some cases, I have to do that progressively if the parameter keeps changing, such as the creatinine clearance case with aminoglycosides. By this, we complete the biopharmaceutics and pharmacokinetic course 2. As usual, if you have any question, please do not hesitate to contact me by the various means that you're already aware of. Have a nice day and enjoy your time.